So it's a great pleasure, everyone, to introduce Dr. Patrick Shenjere, who's been a colleague of mine in Manchester for many years. Patrick is a consultant histopathologist and specialty education lead at the Christie Hospital, which is a premier cancer hospital in Manchester and premier in Europe, in fact. He's a particular international expert on soft tissue tumours. He's the local regional soft tissue tumour lead. He's also a lead skin tumour pathologist, and he also reports hematopathology. He received his primary medical education at the University of Zimbabwe and then did a Masters in Medicine course in histopathology at University of Zimbabwe Medical School. He then did the European Board of Pathology exams before coming to the UK and a specialist training in histopathology in the northwest of England, specifically in Manchester, leading to his appointment as consultant at Christie Hospital. Very, very lucky to have Patrick. He's very in demand for his teaching. He's a real expert on all tumours. The Christie is a specialist tumour hospital. So without taking any more of his time, thank you very much for your time, Patrick, and I'll hand over to you. And thank you, Ava, for facilitating everything as usual as well.
Good. Thank you, Richard, for the kind introduction. I hope you can all see my screen. So I'm going to talk about on small round blue cell tumors, how to approach them diagnostically. And although we call them small round blue cell tumors, you'll find that quite often some of the tumors that fall into this differential diagnosis are not small, and some of them are not blue either. So perhaps the more appropriate title for the talk would be Diagnostic Approach to Round Cell Tumors, because the round cell morphology is principally what most of these tumors share in terms of their morphological appearances. How do we approach the diagnosis for these tumors, which are really a diverse group of tumors in terms of their genetics, morphological appearances, and immunophenotype? And because of that, it can be quite difficult to make a diagnosis, particularly if you don't take into consideration all the things that you need to do to arrive at the right diagnosis. The diagnosis depends on the age of the patient, disease distribution, imaging results, particularly in cases that are involving the bones. Imaging can be quite crucial. Morphological appearances, of course, as histopathologists, that's our prime sort of area of interest. So morphological appearances are important, and we can then, aid the distillation of the diagnosis by use of ancillary studies as immunohistochemical stains and molecular studies. And in this particular group of tumors, there are some tumors that without molecular analysis, you can't really make a confident diagnosis of some of the entities. But that's not to say that without the molecular studies, you can't at least suggest some of the diagnoses. So looking at the age, if one were to look at tumors in young children, particularly, the most common tumors that fall into the group of round cell tumors, embryonal rhabdomyosarcoma, neuroblastoma, and lymphoblastic leukemia. In very young children, they tend to be B lymphoblastic leukemias, as opposed to T lymphoblastic leukemias, which occur in older children and adults. In the adolescent group of patients, the main considerations include alveolar rhabdomyosarcoma, Ewing, sick rearranged sarcoma, big or rearranged sarcoma, desmoplastic small round cell tumor, and small cell osteosarcoma. In older patients, the young adults, the differential diagnosis, in addition to the ones that are seen in the adolescent group, one can add mesenchymal chondrosarcoma, myxoid liposarcoma, the high-grade version of myxoid liposarcoma, what people used to call round cell liposarcomas in the not so distant past. We are now really, the WHO doesn't recommend use of the term round cell liposarcoma, but it's still a term that's that you will see in the literature, and it's a concept to that you should have in mind to help you in some cases to arrive at the right diagnosis. And synovial sarcomas can sometimes fall into this group of tumors. We will look at a case, an example of this case of this entity later on. In the older adults, the most important thing is not to limit oneself to the sarcomas in terms of the differential diagnostic considerations. One ought to think of other tumors that can mimic small round cell sarcomas and things like small cell melanomas, particularly for us in the regions of the world where you have lots of melanoma cases, but melanomas do occur everywhere, and it's something that one ought to always think of. And melanoma is really a great mimic. Small cell carcinoma, particularly in patients with a history of smoking, and again in areas where you have large numbers of white population or Caucasian population, one ought to think of Merkel cell carcinoma. The distribution of the disease is also an important consideration in the diagnostic process. In the head and neck area, if a tumor is in the orbit and it's got a small round blue cell tumor, the main consideration, particularly in sort of young patients, is embryonal rhabdomyosarcoma. In the sinonasal region, one ought to think of all the tumors that are, are particularly, common in that region with a small round cell morphology, things like olfactory neuroblastoma, sinonasal undifferentiated carcinoma, which is really a diagnosis of exclusion, and also small cell neuroendocrine carcinoma and not midline carcinoma. In the skin, one ought to think of melanomas, Merkel cell carcinoma, lymphomas, and myeloid sarcomas. Genitourinary tract, again, rhabdomyosarcoma. Sarcomas tend to occur in that region, especially embryonal rhabdomyosarcoma. And in the abdomen, embryonal rhabdomyosarcoma, desmoplastic small round cell tumor, neuroblastoma, and Swiss NIF deficient neoplasms. If it's a bone tumor, again, the list of differentials is slightly different to that you have to consider in the other sides. And the things of note that one ought to think of, particularly Ewing sarcoma, big or rearranged sarcoma, and small cell osteosarcoma, particularly in sort of young patients. Small cell osteosarcoma is interesting in the sense that people have reported bone formation in some of the big or rearranged sarcomas, and some people are now believing that at least a subset of what people have called small cell osteosarcomas in the past are probably examples of big or rearranged sarcomas. So it's interesting. I think it will be interesting for somebody to actually do a systematic study to see what proportion of tumors diagnosed as small cell osteosarcomas fall into the group of big or rearranged sarcomas. And mesenchymal chondrosarcoma, I think, is an important consideration as well in the bone. And these other tumors, again, will depend on the clinical context and the age of the patient. So just to briefly touch on the classification of small round blue cell tumors, in the 4th edition of the WHO classification, it was simple. We had mainly 2 groups of tumors, Ewing sarcomas and undifferentiated small round cell sarcomas, NOS, or so-called Ewing-like sarcomas. But in the updated 5th edition of the WHO, we now have a lot more other tumors, which are primarily defined by the underlying genetic abnormalities. So in some of these cases, you really ought to have investigated for the underlying genetic abnormalities to arrive at the right or rather the correct diagnosis. But that's not to say again that with morphology and immunohistochemistry, one cannot at least suggest or strongly favor some of these entities, and we will explore some of these in a short while. So the commonest small round cell tumor is Ewing sarcoma, which was described by Dr. James Ewing in 1921. And over the years, we have realized that there were other entities which were initially thought to be entities that are different from Ewing sarcomas that are actually part of the spectrum, so-called PNET or peripheral neuroectodermal tumor, or what some people used to call peripheral neuroectodermal neuroepithelioma, and Askin tumor, which are tumors occurring in the thoracolumbar region. They are all part of the same family of tumors, Ewing family of tumors. And this was then confirmed in the 80s by the discovery of the underlying genetic abnormalities involving involving chromosome 12 and 22, and identification of the EWSR1 gene rearrangement in these tumors. So Ewing sarcoma is most common in children and young adults. And in the young patients, bone tumors are more common than extraskeletal tumors. Whereas in the adult population, soft tissue tumors are more common than the primary bone tumors in Ewing sarcomas. In the bones, they tend to affect the diaphysis of long bones, pelvis and ribs. Those are the commonly affected sites. And sometimes in some cases, radiology can be helpful in sort of narrowing your differential diagnosis. In terms of immunohistochemistry, CD99 is the one which I'm sure we've all heard of, and that we use in the diagnosis of Ewing sarcoma. The majority of Ewing sarcomas are positive for CD99, and it tends to be a diffuse membranous staining pattern. But not all Ewing sarcomas are positive for CD99. You have to remember that there's a small percentage of cases that are negative for one reason or another. And those cases can be particularly difficult to diagnose. And those are the cases where one needs to rely on other ancillary studies to arrive at the diagnosis. And over the past few years, NKX 2.2 has emerged as a very sensitive marker for this particular tumor. It is, however, not 100% specific. Some of the mimics that one has to consider in the differential diagnosis can show NKX 2.2 positivity. We've seen it in sick rearranged sarcomas, a small proportion again of big or rearranged sarcomas. But if you have a combination of diffuse CD99 staining and NKX2, it usually, points towards the diagnosis of Ewing. Fly1 is positive in the vast majority of cases, but Fly1 is a very non-specific marker to such an extent that in our practice, we actually don't use it that often because it stains a lot of tumors, including the ones that you would consider in the differential diagnosis of Ewing. And the other thing to remember is that up to about a third of cases can show cytokeratin positivity. And because of the cytokeratin positivity, particularly in the older population, it's quite easy for one to think of small cell carcinoma. And in some cases, especially where you have some synaptophysin positivity, it can be quite misleading in that scenario. So in terms of molecular analysis, the vast majority of these tumors have got EWS-SARA1 and Fly1 rearrangement. A small proportion have EWS-SARA1 egg rearrangement, and an even smaller proportion will have FAS instead of EWS-SARA1 as the TET family gene. And these can be tested using fish studies, and in our lab, we tend nowadays to use more NGS analysis, which is quite good in the sense that you can get the translocation partner, whereas the fish studies, sometimes you only get rearrangement of one of the gene, particularly if you use some of the break apart probes. If you have a Fly1 EWS-SARA1 break apart probe, and then you have a tumor with EWS-SARA1 egg rearrangement, you can only, conclude that you have got an EWS-SARA1 rearrangement, but you won't know the partner gene. And it can be quite crucial in some cases because EWS-SARA1 is not, what can I say? It's particularly a conspicuous gene. There are a lot of other tumors, and some of which are with similar morphology to Ewing sarcoma that can have EWS-SARA1 rearrangement. And in those tumors, it's crucial to actually know the translocation partner for one to arrive at the right diagnosis. The sick rearranged tumors, these most commonly occur in young adults. I think the youngest patient we have seen in our hospital here was about 9-10 years old, and typically the tumors occur in the deep soft tissues of the extremities and trunk, and the morphological appearances can be quite variable. In some cases, you can have, your small round blue cell tumor appearance with sheets of cells with scanty cytoplasm and hyperchromatic nuclei. In some other cases, the cells can be slightly more spindled in appearance, and the stroma can be myxoid. And it's those cases that can be particularly difficult to diagnose without, use of ancillary studies. And so in some cases, it can be quite difficult to even think of sick rearranged sarcoma if you haven't done some of the immunostains to help you to narrow the differential diagnosis. And these tumors, unlike Ewing sarcomas, they tend to have more prominent nucleoli. And in terms of their immunophenotype, CD99 is positive in the vast majority of cases, but it tends to be patchy. And, more cytoplasmic and membranous staining, as opposed to Ewing sarcoma, where you get diffuse membranous staining in most cases. The helpful immunos that can make one think of sick rearranged sarcomas are WT1 and ETV4. If you have that in your lab, WT1 is positive in up to about 90% of cases, and if one has a tumor where it's showing patchy CD99 positivity, WT1, then one ought to think of the sick rearranged sarcomas and do the necessary molecular investigations to arrive at the right diagnosis. A small proportion can show cytokeratin positivity, and this can be a source of diagnostic difficulties. And the major problem with this particular entity is the fact that even though, in most cases we actually say one ought to do the molecular studies to arrive at the right diagnosis, a significant proportion of cases, can be quite difficult to investigate using, the current commonly used molecular studies modalities. Up to about 15% of cases will have a negative FISH result, mainly because of the cryptic fusions in those tumors. And in those tumors also, even if you do NGS analysis, you can get the test failing to detect the gene fusion, even though it is still present. So it's something to bear in mind that a negative molecular result doesn't necessarily mean that you are not dealing with this particular entity. Why is it important to make this diagnosis? It's important because these tumors have got much poorer prognosis as compared to Ewing sarcoma, and the patients tend not to respond to the conventional Ewing sarcoma chemotherapy that's used in oncology. Sarcomas with BCO genetic alterations. These represent about 5 to 6% of the tumors that were traditionally called Ewing-like sarcomas. And the anatomical distribution is quite similar to that of Ewing. And the patients tend to be mainly adolescent patients, and there is a striking male preponderance. And in terms of morphology, you can get cases that look very much like Ewing, and you can also get some cases that look much more spindly with a myxoid stroma, to such an extent that you may not even think of the tumor as a small round cell tumor. And the stroma can be variable, can be fibrocollagenous, and in some cases predominantly myxoid, and you tend to have a rich capillary network in the background in some cases. And we have seen some examples which are quite paucicellular, with lots of collagenous stroma. In those cases, particularly on small biopsies, can be quite difficult to diagnose, because one may not even think of this particular entity. And that's where, if you do the necessary immunos, it can be helpful. BCO immuno is quite helpful. It's really positive in almost all the cases that of BCO rearranged sarcomas. But again, like all immunos, initially it was thought to be very specific for this particular entity, but with use over the years now, we realize that it's not that specific. It can stain other things, so you can't really rely on it as your sole surrogate marker for the BCO rearrangement in these tumors. Other helpful immunos are CCNB3, cyclin D1, SAT-B2, and TLE1. All these markers are, except for this CCNB3, they are really not specific. But if you take them together with the morphological appearances and the BCO immuno, it can be quite helpful. CD99 can be usually in a patchy manner in about half of cases of BCO rearranged sarcomas. And you can do FISH or NGS analysis to confirm the underlying genetic abnormality. So that was just a quick update on the relatively more recently described entities. So I will now use a few cases to illustrate some of the tumors that fall into the differential of small round blue cell tumors. The first case is that of a 25-year-old male who had a mass in the left zygomatic area, and this was biopsied and later resected. And the tumor, as you can see here, is composed of sheets of small round blue cells, which are, in places divided into sort of vague nests by delicate fibrovascular stroma, scattered apoptotic bodies, and some mitosis were also seen. And this tumor was positive for desmin and diffusely positive for myogenin and MyoD1. So I don't know if you're able to speak. Do you want to volunteer your diagnosis? The tumor was negative for all these other markers listed here. No volunteers, or you can put it in the chat. Nothing forthcoming here. So this is an alveolar rhabdomyosarcoma, which was really a solid variant of alveolar rhabdomyosarcomas, rhabdomyosarcoma rather. And alveolar rhabdomyosarcomas, they've got a peak incidence in the adolescent and young adult group of patients. It's quite rare in older patients, and that's not to say, they can't occur. Commonly affect the head and neck area, followed by the trunk and pelvis. And these tumors have got poor prognosis, and they tend to metastasize to the lung and lymph nodes. Just another case to perhaps illustrate that use of immunohistochemistry in this in the differential diagnosis of small round blue cell tumors can be tricky in some cases. So this was a 63-year-old female patient who had what was described as a pharyngeal mass, and it was biopsied, and the biopsy looked like this. Again, sheets of small round blue cells, focally, divided by fibrovascular stroma, delicate fibrovascular stroma, and slightly higher power, again, to show the division by the delicate fibrovascular stroma here. And this tumor showed dot-like paranuclear staining for cytokeratin, and this is MNF116, and showed, relatively diffuse staining for synaptophysin. and was also diffusely positive for CD56. And because of that combination of immunostains and morphological appearance, and the fact that the patient was an elderly or older patient, I must say, not elderly, this was called a neuroendocrine carcinoma, a small cell neuroendocrine carcinoma, and was referred to our institution where we did additional immunostains. And the tumor was diffusely positive for desmin, also diffusely positive for myogenin. So this was another example of a solid variant of alveolar rhabdomyosarcoma. So here, a combination of the tumor occurring in an older adult and a sort of slightly atypical sort of immunophenotype, if you like, because of the expression of neuroendocrine markers and cytokeratin. It was called a carcinoma when in fact it's a rhabdomyosarcoma. So immunostains, if you use them without looking at the morphological appearances and looking to see if the other features are really fit, can be misleading. So one shouldn't solely rely on immunostains. If you take into consideration the morphological appearances and the clinical context, sometimes it can be quite helpful to arrive at the right diagnosis. This particular case, for us, it was because of this morphology here. It didn't really, this packeted appearance. That's what made us think of a rhabdomyosarcoma rather than just a small cell carcinoma. And if you look here in this particular field here, there's a giant cell here. In alveolar rhabdomyosarcomas, sometimes you get giant cells, scattered giant cells with a wreath-like arrangement of nuclei, which can be a diagnostic clue in those cases. So alveolar rhabdomyosarcomas, with immunos, I think the diagnosis is relatively easy. Desmin and usually diffuse staining for myogenin and MyoD1. If you get a tumor where you are thinking of alveolar rhabdomyosarcoma and you are only getting focal staining, particularly for myogenin, you ought to think again, because alveolar rhabdomyosarcomas typically do show diffuse staining for myogenin. Cytokeratin can be positive in a proportion of cases, and neuroendocrine markers can be positive. Usually it's sort of focal to patchy staining, but we have seen examples with quite diffuse staining for particularly for synaptophysin. CD56, people use it. I know people who do lung pathology, particularly, they like using CD56 as an additional neuroendocrine marker, but CD56 is a very non-specific marker and it stains a lot of things, and it's a marker that one ought to use with caution, especially if you are not dealing with hemolymphoid tumors. In terms of the molecular genetics, the vast majority of alveolar rhabdomyosarcomas will have the PAX3 FOXO1 fusion, but a smaller proportion have got PAX7 instead of the PAX3. Another tumor that most people may not think of in the differential diagnosis of small round blue cell tumors or round cells tumors is poorly differentiated synovial sarcoma, particularly if you are dealing with a small biopsy. I think it's important to bear in mind that it's a possibility, especially in sort of young adults or older patients. If one gets a hemangioparasitic pattern, it can be a diagnostic clue. But in some cases, you just get sheets of small round blue cells without any distinct pattern. That's where doing the immunos and doing the molecular studies can be quite helpful. In excision samples, it's usually not a difficult diagnosis to make because almost invariably you will get areas with conventional, spindle cell morphology or biphasic pattern in cases of poorly differentiated synovial sarcomas. It's in when you get small biopsies, that's when it can be quite tricky. And also it's compounded by the fact that the immunophenotype is really not that specific. Most cases will show some staining for cytokeratins, which is usually focal, patchy EMA staining, but you can get this pattern of staining in the other small round blue cell tumors as well. TLE1 is a marker which, when it was first introduced, was really, promoted as a very good marker for synovial sarcomas, but we now know that it's a very non-specific marker to such an extent that in our lab we don't really use it for diagnosing synovial sarcomas. CD99 can be positive, and in most cases it's partially positive, and because of the CD99 staining, it's again quite easy to think of Ewing sarcoma in your if you are looking at a small biopsy and trying to reach at a diagnosis, which is why for our biopsies, we for this group of tumors, we almost invariably will, in addition to doing the immunostains, we will do molecular studies as well. To arrive at the right diagnosis. You can get focal staining for S100 in synovial sarcomas, which can be a source of diagnostic difficulties, particularly in some cases where one is thinking of MPNSTs or even melanomas. And over the past few years, a new antibody is now commercially, available, which is thought to be quite specific and very sensitive for this particular group of tumor. We don't have this antibody, so I don't have really much experience in its use. In terms of molecular genetics, the majority of patients cases will have the SS18, SSX1 rearrangement. A smaller proportion will have SSX2 instead of the SSX1. And there are other rare variants which you just ought to know that they're in existence, but they're not so rare that they're not particularly important to remember. So I'll move on to a different sort of case, another tumor which again may occasionally fall into the differential diagnosis of small round blue cell tumors, especially when one is dealing with small biopsies. That's when one really ought to think of this particular entity. So this was a biopsy from a 46-year-old female with what was described as a deep thigh mass. And that's what it looked like. You can see there are these small round blue cells set in a sort of myxoid stroma. And if one looks carefully, you can just about pick out some, what looks like vessels in the background, which is really an important diagnostic clue in this particular entity. And this is another view where you have the small round blue cell appearance there, and here it's looking much more, myxoid. with lipoblasts. If you get the lipoblasts, then this particular diagnosis becomes very easy to make, and you immediately think of a myxoid liposarcoma, or in this particular case, it's a high-grade myxoid liposarcoma, what people used to call round cell liposarcoma. It's when you just get areas like this middle panel here, and it's a small biopsy. That's where it can be quite tricky. If you don't have access to ancillary studies, one can use even some endothelial markers to highlight the delicate chicken wire vascular pattern in the background. So this is really an example of a high-grade liposarcoma. In resection samples, again, it's usually not a problem, because quite often you get other areas with the more typical appearance of a myxoid liposarcoma, where you've got these round and stellate-shaped cells in abundant myxoid stroma containing the arborizing chicken wire background capillary network. Rare examples of myxoid liposarcomas can have some unusual appearances. You can have ibenoma-like areas. You can have some heterologous cartilaginous or even rhabdomyoblastic differentiation. You can have areas which look very much like a mature adipocytic tumor, looking more like a lipoma. And you have got other rare appearances patterns that you can see in these particular tumors that I've listed there. In terms of immunos, S100 is variably positive in the high-grade component, so it can act as a trigger to think of a myxoid liposarcoma, particularly in cases where you just have sheets of small round blue cells. If you get S100 positivity, if you hadn't thought of high-grade myxoid liposarcoma, it can be helpful. And over the past few years, again, a new antibody, DDIT3, has become commercially available, which again is said to be highly sensitive and specific for myxoid liposarcomas. I don't have any experience in its use because we don't have it in our laboratory. And for most cases, I think one can make a diagnosis of myxoid liposarcomas really without resorting to do molecular studies. But if you have to do, if you do fish for DDIT3, it's quite sensitive and specific for this particular entity. And in our cases, in our hospital, we also tend to look for secondary genetic abnormalities, TP53, CDKN2A alterations, which are thought to have to play a role in the prognosis of these tumors. Another entity which falls in the differential diagnosis of small round blue cell tumors is this tumor here. If you see the history here, it's an 18-year-old male patient with a disseminated intra-abdominal tumor. If you think, if you go back to the, first few slides I showed, where we, mentioned the age of the patient, the disease distribution. And in this particular case, the sex is actually also quite important. So it's a sort of adolescent male patient with disseminated intra-abdominal disease. Even before looking at the slide, one can think of a particular entity, as a possibility here. And when you look at the slide, I think the diagnosis becomes pretty obvious. there are these irregular nests of small round blue cells divided by a desmoplastic stroma. And doing immunos, the tumor is quite polyphenotypic. It's showing expression of desmin, cytokeratins, and WT1. And this is a desmoplastic small round cell tumor. This is a tumor which typically affects adolescent and young adult patients with a marked male preponderance. And as I alluded to earlier on, the vast majority of patients present with a disseminated intra-abdominal disease. And the immunophenotype, again, it's a polyphenotypic immunoprofile. Because of the staining for desmin, again, it then becomes important to look for the negative markers to exclude. If you look for skeletal muscle differentiation doing myogenin, MyoD1 to exclude a rhabdo. That's important. And in difficult cases, one can do molecular studies, but in the vast majority of cases, I think one can make a diagnosis of this particular entity without actually relying on molecular studies. Again, this is perhaps a zebra, particularly for most of us who practice in sub-Saharan Africa. So this is a 70-year-old female neck mass, and that's what it looked like. Again, high-grade tumor, small to medium-sized cells with hyperchromatic nuclei, scanty cytoplasm, lots of necrosis. Again, the age of the patient is important. And in this case, actually, the rest of the patient is important as well. This was a Caucasian patient, and the tumor showed cytokeratin positivity, and it showed this characteristic paranuclear dot-like staining for CK20 and CAM5.2, and was positive for neuroendocrine markers. So this is a Merkel cell carcinoma. Again, if one thinks of it, the diagnosis is not that difficult, but this is a tumor which is very rare in non-white population. Lastly, I think I would just show you a case of a tumor which is, not a sarcoma and not a carcinoma. This was from a 42-year-old male patient with a history of smoking who presented with a mediastinal mass. And because of the history of smoking, clinically they were thinking whether this is a small cell carcinoma. And that's what it looked like, core biopsies. And on these core biopsies, one can think of, because it's in the mediastinum, can think, could this be a thymoma or some other, tumor? On immunohistochemistry, it was positive for T cell markers and CD10 with co-expression of TDT. So this was a lymphoblastic lymphoma. Again, this in our practice, we see lymphoblastic lymphomas being missed mainly because, I think people wouldn't have included it in their differential diagnosis. And if you really don't think of lymphoblastic leukemia, even if you do hemolymphoid markers, you may not be able to make the diagnosis still, because you won't have done TDT, which is quite useful in arriving at the right diagnosis. So to conclude, really, for round cell tumors or round cell sarcomas, one can use a combination of clinical information morphological appearances, and use of immunohistochemistry together with radiology and molecular studies to arrive at the right diagnosis. It's important to label these tumors correctly, because the treatment quite often can be, different, and also the prognosis varies depending on the diagnosis. Any questions?
Well, thank you very much, Patrick. I wasn't able to attend most of it, I'm afraid, but I did catch the last few cases. See, there were some questions in the chat, as saw some responses in the chat as we went along. I don't know if there's
All right.
Any other questions from the audience. So I suppose one question is how many people in the audience would have access to TDT for? I'm just wondering how many in the audience would have access to TDT for diagnosing lymphoblastic lymphoma. Anyone able to put their hands up or put it in the chat? No, no, I can't see any. How see anyone's responded or not. Are there any questions from the audience? For Dr. Shenjere.
Yes, if you have any questions, or you can email me, feel free to email me on the email that's displayed on the screen there. Thank you.
Yeah. Okay. Well, thank you. If there are no questions, I'm sorry about that, Patrick. I think it was very clear. Really, the few cases that I managed to see at the end, because I had another appointment at the time, were really clearly explained. I think the point you made at the end about the lymphoblastic is it's an easy one to miss if you don't think about it, because the immunos often, if you don't do that TDT, they often point you somewhere else.
Yeah.
So Patrick's email is up there. Please feel free to email him any questions, and this recording will go out to you all, so you will have that as well. Just a final chance for any questions in the last minute remaining from anyone, or a vote of thanks for Patrick for his talk.
You're welcome. Yeah. Thank you. Bye.
Yeah. Okay. Thank you, Patrick.
Bye.
Next week it'll be Dr. Tegan Miller from Manchester Royal Infirmary, a colleague of mine, who will be talking about urological pathology. So please feel free to share the presentation, the Zoom link to your colleagues wherever you are. We want as many people to join as possible. And so Tegan is our urology lead, so that'll be a very good talk as well. Patrick, thank you very much.